Welcome to our panel on the evolving role of the general practitioner and health team in remote and rural health. My name is Nicholas Torres, and I serve in the capacity of the Executive Director of the Network Towards Unity for Health. We first want to welcome our members. We hope that you find these virtual symposiums to be valuable to your work and allow for year-round engagement with TUFH, Towards Unity for Health. So I'd first like to welcome our panelists. We have Margaret Tromp, who is a family physician in Picton in Canada, where she has a full spectrum practice. She's a member of the Prince Edward Family Health Team and an adjunct associate professor in the Department of Family Medicine at Queen's University. Margaret spent her early career working in remote areas, including Ethiopia, Labrador, Northern Ontario, and Saskatchewan. So welcome, Margaret.
Thank you.
We have Pratyush Kumar, who is a physician from the Department of Geriatrics at Patna Medical College Hospital in Patna, Bihar in India. And he's also the co-author of the Rural Health Scenario, the Role of Family Medicine, Academy of Family Physicians of India, in which case we'll be talking a little bit about his position paper. So welcome, Pratyush.
Thank you.
And we also have Raymond Markham, who is Executive Director from the Rural Coordination Center of BC at the University of British Columbia. Welcome, Ray.
Thanks, Nick.
And each panelist will have an opportunity in the first question to provide a little bit more in depth of the introduction of their work and themselves. But to give our participants a little context, I'd first like to quote Pratyush Kumar in his position paper, because I thought it was a great introduction in terms of what our conversation is about. And the paper states that half the world's people currently live in rural and remote areas. About 70% of the world's 1.4 billion people who are extremely poor live in rural areas. The problem is that the majority of healthcare providers prefer to serve in urban areas. A country's approach must systematically and simultaneously address legal coverage and rights, health worker shortages, extension of healthcare protection, and quality of care. Only then can equitable access for all be fully achieved. So I think that sets the context for the conversation. But now I'd like to turn it over to our panelists, and each one of you take a few minutes to introduce yourselves, your organization, and your work related to this topic, the evolving role of the general practitioner health team in remote health. And Pratyush, since we quoted your paper, would you like to start?
Yeah, sure. So I'm Dr. Pratyush Kumar. I'm a young family doctor from India, and I have been in family medicine. And I currently chair the WONCA Rural South Asia Group. It's a rural health group in South Asia, and also the executive member of WONCA, which is the World Organization of Family Doctors, representing around 1.5 lakhs of family doctors all over the world. And currently, my passion is regarding rural healthcare to serve those who are vulnerable population there in the rural and remote population, and to strengthen the primary healthcare in India and South Asia and globally. And that's what I work on. And I work on the policy papers regarding the primary healthcare models, which is much more affordable and also accessible to our population, which is in low and middle income countries which can't afford affordability is the main concern. And that's where my focus is. Thank you.
So thank you for that introduction, and let me turn it over to Margaret, and you can maybe talk about a little bit about your work.
Yes, I'm a family physician in a small town in southern Ontario. Where I presently work is rural but not remote. I'm the president of the Society of Rural Physicians of Canada, and this group has been around for about 25 to 30 years. It was established initially to support doctors who worked in rural areas and to advocate on their behalf. So we do support, such as we have an annual conference where it's educational, but I think one of the great benefits is gets a chance for family doctors to get together and discuss issues of common interest. As well, we have a Rural Med Listserv, which is a discussion group where people discuss issues. Some of them are medical, some of them are political, some of them are lifestyle, but it just gives a chance for people to talk about these things. Some of the initiatives we're having right now, for the last few years, we've been working with the College of Family Physicians on something called the Rural Roadmap, which is a list of recommendations to improve. I think its focus is to increase the number of people who choose to work in rural areas and to appropriately educate them for that. And the initial part of the Rural Roadmap was coming up with recommendations which involve the Society of Rural Physicians as well as the college. The college is the group that is responsible for training physicians in Canada. We're now at a stage where we're talking about how do we implement these recommendations, and for that we have involved many different medical organizations, such as the nursing organizations, the physician recruiting organizations, the hospital administration organizations, such as that, because we're aware that it takes many different groups to get together to make these things happen. So yeah, that's where we are right now with that.
Great, thank you, Margaret. And I think
You're welcome.
the participants are realizing that, Margaret and Pratyush, you're representing much more than your own experience because you're part of these larger groups in terms of physicians in remote and rural health. With that, let me turn it over to Ray for the introduction.
Yeah, great. Thanks, Nick. Hi, everyone. So, Raymond Markham. I'm a GP in Belmont, a little town in British Columbia. So the other end of British Columbia, of Canada. So a few thousand kilometers away from Margaret. Little town of about 1,000 people. And I've been working there for the last 17 years. Originally, as you may tell from my accent, not a Canadian accent, born and bred in Zimbabwe. I do some work with capacity building between Zimbabwe and Canada. Been doing that for the last kind of 5 or so years. So that's one piece of the work that I look at doing, kind of just wanted to flag, and I think has relevance to this conversation. I also kind of am involved with a group called the Rural Coordination Center of BC. And I think that's the main reason I was invited onto this panel. So I help lead that organization, have done it for the last 3 years or so. It's a little bit of an interesting organization. It's fundamentally kind of really about improving the health of rural patients and communities. We're based in British Columbia, born out of conflict initially between rural physicians and government, and really got into now in a place of a collaborative relationship. It's quite one of the things that attracts me is the service kind of piece of the Rural Coordination Center built into its name. So although we're a multi-million-dollar organization, we're actually not an entity. Where our kind of function is to serve, and kind of we're really dependent on our partners for kind of providing those entity type functions, like the physical accountability, all of that kind of stuff. So which is quite interesting. We really work around growing relationships, so collaboration and partnerships. We're built as a network, so things like feedback loops, iterative evaluation, a learning organization, a learning network. Is the way that we were built by the people who established us 20 years ago, Bob Willard being one of them, Granger Avery, Mary Johnson was quite involved in that whole process. There's obviously a coordination function in our work, which is really fundamentally being a knowledge broker in gaps and overlaps. So not trying to step into spaces where there are overlaps, but coordinate, and in gaps, sometimes we do some project work. There's an innovation function to the work that we're doing, which is really about systems change. And we are funded, the way that we're funded in this province is kind of based on physicians, but so it's physician funding, but recognizing the interprofessional team, we recognize our place as kind of physicians and providers as a part of the team providing care, and certainly in British Columbia, I can get to that later on. Not all care is provided by physicians, or even physicians have hands on all care, so they need to kind of work together. The type of things, what we do is kind of, we have an action piece, which is kind of an operations piece for the Joint Standing Committee on Rural Issues, which is our funder. We do a lot of work around education, interprofessional education, and we have this inquiry function that we look at doing, which is kind of really a little bit of a think tank idea, and then looking at influencing policy. So that's it in a nutshell.
So thanks, Ray. So again, I think the three of you represent sort of a general trend, and that leads into the first really question. Like and that is sort of what is the evolving role and responsibility of the general practitioner? And I guess I highlight the role evolving because it's probably different in different countries or so. And so what's the comparison? And maybe there's themes across them, but it may be including the management of emergencies, treatment of medical and surgical specialty, care of the entire family, referrals, follow up. But sort of like, can you guys each talk a little bit about how that role, what that currently role is, maybe even some of the challenges that go with it, but really talk about the evolving role and how that, in a sense, contributes to the healthcare team, in a sense. And I think we'll just kind of follow the same order. So, Pratyush, would you like to start?
Yeah. So the thing is that the evolving role is changing. Earlier, we were much more concerned about uh, healthcare is taken as sick care, but now the whole paradigm of healthcare is from sick to healthcare. And we talk about healthcare, the stress has been shifted from curative services to providing preventive, promotive, rehabilitative, and palliative care services have been included in the treatment services which we offer at primary care level. And for general physician to get ready with these changes, obviously emergency, and when we say about comprehensive care, it includes everything like emergencies, maternal child health, palliative, end of life care. It's all a part of thing. But apart from all those things, there are some other issues which are much more evolving and also a part of our responsibilities, like cultural competencies. Uh, Cultural competencies, because of we have got lots of migrant population all over the world, and each population, diverse population, which home cater have different cultural needs, and we must be culturally competent to offer them appropriate care. That's what primary health care is, which is evolving role of us. Then also about global peace. Without global peace, there can't be any health. We can't even dream of achieving universal health coverage and health for all. Obviously, migrant healthcare is an issue, and that we must take care of. And but apart from that, also have lots of talk about stewardship. We have talked about antibiotic stewardship, but there's much more bigger role of resource stewardship, because in low and middle countries from where I come from, we spend very little on our healthcare spendings. Our spendings are just around 1% of our total GDP. And but even though in that 1%, there's need how better we prioritize our resources, how better we channelize our resources into making our healthcare services, health outcomes, the efficiency of health outcomes should improve even within less spending. Because healthcare is not only about how much money we spend, and healthcare is not only about the infrastructure we develop, but it's all about the health outcomes which we get out of the resources which we spend on our symptoms. Then obviously the latest developments regarding the quaternary care, regarding the quality and safety, and obviously the planetary health, regarding environment health, air pollution, and all these things. These also things comes under our purview, that as practitioners, the point of first contact, how we deal with all these issues. And obviously follow-ups, continuity of care, these all are primary care issues. And these issues on and whole comes under our purview, and we need to systematically deal with the issue. Obviously, we have the problems of health workforce shortages are there, resource shortages are there. There's also obviously there's a fragmentation of services are there. Primary care, secondary care, and tertiary care works in silos, and there's no proper referral mechanisms out there. We need to build a system which is much more integrated, works in a very closed loops, and the causes remains the same, and that's why we can improve the health outcomes. Thank you.
So Margaret, let me just turn it over to you, and you can answer the question, or you can provide any comments to what Pratyush was saying, and sort of just, again, we're moving this towards a conversation, so feel free to add whatever you want, Margaret.
Sure, thank you. Yeah, so as I listen, I hear a very broad range of things that primary care can involve. And I think in Canada, we're seeing two sort of opposing trends happening. And I think this is probably happening throughout the world. primary care by some is seen a little bit too all-encompassing and a little bit scary because it can potentially involve so many different things. And in family medicine and in Canada, there's on one hand a trend towards specialization and people doing focused practice where they concentrate on one area. And at the same time, we're also encouraging people to be not focused and to be much more generalist in their approach. So I think one of the challenges for us moving forward is to discourage people from becoming too focused and give them the skills so that they feel that they can be very generalist in their approaches. And I know when people are doing their training, there's still a concern that they have to know everything when they graduate. The College of Family Physicians has a program called the First 5 Years, but this is just to emphasize that a lot of the knowledge and comfort level that you come to in family medicine is after your residency and in your first 5 years of actual training. And I think one of the hopes of this is to get away from that emphasis that you have to feel completely competent and ready to do everything at your time of graduation. There is definitely more emphasis on working in teams now. This varies a little bit from province to province. In our province, we have family health teams that involve nurses and nurse practitioners and dietitians and that type of thing. So you're looking after patients in more team-based approaches. I will say it's been my impression that when you talk, say, for example, about nurse practitioners, that they say when they graduate nurse practitioners, most nurse practitioners, like most physicians, also prefer to work in urban areas for a variety of reasons. So I think we can't just assume that by using or training allied health professionals that we're going to solve the rural medicine problems, because I think that desire to live in more urban areas is for a vast number of reasons, including family, education of children, spousal employment, that type of thing, and all those issues have to be dealt with. Obviously, training is important to feel comfortable to go out into rural areas, but I don't think it's sufficient.
So thanks, Margaret. And Ray, maybe if I turn it over to you, maybe you could expand upon that. And also, what's the role of telehealth within rural communities? And is that affecting the role of the general practitioners or the health team? Just maybe to add that to the question.
Sure, yeah, great, thanks, Nick. And first of all, kind of totally agree with where Pratyush was going and with Margaret. So certainly, I think, I'm not going to belabor the point, but getting upstream around the social determinants of health is a huge part of the role of a primary care physician, of a general practitioner, and kind of then picking up on this idea of generalism, and would really frame it as generalism. I mean, Monica and Rahul have made some really interesting comments on the chat bar around kind of, that the family physicians are one part of the piece, and a lot of the world, certainly the work that I do in Zimbabwe, the majority of care is not actually provided by physicians. So then where is the role of the physician in providing care in this as a part of the team? And I think one of the best definitions that I've seen of generalism is the Royal College of kind of within Canada of definition of generalism, which is a specialist college, quite interestingly. And they really contextualize generalism around the community, so where care is delivered, the services that are available, as well as the skill sets of the providers. And so I think it is very context dependent. We see a lot of variation kind of even within Canada, from urban to small urban to rural to remote, as to kind of what the role of a general practitioner would be in each of those contexts. And then just to pick up on your point, Nick, it's I think virtual care, so the role of technology in enhancing or as an extender of services and of people and skill sets is hugely important. We've traditionally lived in society which says, you know, if you're in a rural area, because you don't have geographic proximity to certain services, you can't get those services. And so there is this kind of equity gap. And I think virtual care has a potential of actually narrowing that equity gap. We see it in British Columbia now in a number of First Nations communities, a lot of innovation happening with our First Nations communities in this area where traditionally they really had very limited access, you know, transport being a social, I think we need to see that as a social determinant of health, and kind of financially not being able to actually get to care, where they've moved into kind of clinic models where they can't necessarily sustain kind of ongoing service with a general practitioner and a nurse and a community worker and all of that kind of stuff, but they have kind of the physician will come into the community, build those longitudinal relationships with the community, and maintain those longitudinal relationships even while not physically in community by virtual care, virtually supporting the rest of the team. So I think virtual care is something we need to look at as a way of extending. And I mean, we're even experimenting with that work with our work, kind of connecting and looking at developing capacity within the Canadian, and so bidirectional capacity building between the work I'm doing in Canada and Zimbabwe. So for instance, ultrasound training is an area that we're interested in. So how do we support development of faculty kind of in ultrasound to provide ultrasound? And I think that's a point of care ultrasound as a part of primary care, a part of, again, that role that a physician, family generalist physician can provide. And so connecting kind of faculty within Canada virtually to faculty and training in Zimbabwe is another way of doing that. So I think we're at a really exciting and interesting place where we can actually start seeing healthcare as an ecosystem. I do believe, like in countries like Canada, where we struggle with the cost of healthcare, you know, over half of our gross domestic product is spent in healthcare. And a big part of that is, I think we need, as Margaret was alluding to, move into that generalist approach. I think that's something that's really necessary and something we can learn from kind of the lower resource environments where generalism is just as it's more of a front and center out of necessity in rural, it's more front and center in the kind of lower resource countries out of necessity. And I think linking those areas of practice, I think, has value for both sides. And virtual care, I think, plays a big part of that potentially.
Great, thanks, Ray. And Pratyush, you'll turning it back to you. I think the conversation kind of leads me to the next evolution of the question, which a lot of our participants and you have sort of referred to as this health team. And, you know, I think Margaret said it well. It's like, you know, one of the ideas to get more and more family physicians or even nurse practitioners to want to live in rural and remote, but oftentimes that doesn't happen. So then the question becomes like, who is this health team? And how does the health team actually work together to provide care? Maybe it's primary care, but also specialty care to the different people that need it. You know, there was a comment in the chat box about, you know, what's the role of midwives and, you know, or gynecologists. You know, there's only 1 to 7,000 people in India. So again, you can't provide that specialty care. So the question is like, how does this health team work? So the next question I would like is like, first of all, in your perspective, who is this health team? Who makes up the health team? And then, you know, and how does that health team really work with family care physicians or others working towards universal access and equitable health care? So, Pratyush?
Yeah. So the thing is that as our system is moving from sick care to health care and providing more of preventive, promotive, and rehabilitative care, the whole system of a physician-dominant health team is shifting towards medical teams, towards a social care team. So earlier in the primary healthcare teams, only we had a medical team consisting of family physicians, nurses, midwives. But now we also have health activists, financial managers, policymakers, and these all are part of our primary care teams. If you look at a recent, the declaration of Astana Declaration, which we recently had at Astana, if you look at the draft document, they included all the words like family doctors, nurses, health workers. But in the final document, they removed everything and just they included primary care teams. It's because that they realize that there's a need to take care of all those population, all those working people like social workers who have got great roles in improving the health systems by information, education, and communication strategies. So we need to realize that apart from medical teams, there is also a social team, which should be a part of primary care teams. So these consist of our health teams, and how they make the system better is by making our healthcare system much more accessible. Earlier, the trend was that the patient used to come to the offices, but now the demand is that the healthcare should be delivered at the point where it's needed. So there is much more demand of home delivery of health services, and these bridges is being mended by these health workers who work on the ground and make up all the team. But obviously, we must also take care that our health team should complement each other. It should not replace each other. Like a nurse should never be replaced by a health worker. A doctor should not be replaced by a nurse. It should not be replacement kind of strategy. If it's a replacement, then the quality will suffer. So we must take care that it should complement each other's. Like a nurse should complement a physician, a health worker should complement nurses, midwives, and they work as a team. It's not a matter of who is the supreme leader or who is the junior one. It's a matter of teamwork, and in teamwork, everyone has got a defined role, and they need to practice their role very efficiently to bring out the better health outcomes. So complementary role will help to get the better outcomes. That's my comment for this. Thank you.
So thank you. So I heard that, there's the health team is composed of not just health workers, but social workers. You've got midwives in there, nurses. You also saw the new phenomenon sometimes is going on at home visitors who may not be in healthcare, but are able to get into people's homes. As you said, it's really about providing care. And so Margaret, maybe, I would imagine going back to telehealth becomes then a tool for how this team can really integrate and communicate with each other, as each team member has a different role, but not necessarily full knowledgeable about the full thing. And maybe you can even comment, how does shared health systems or health data systems play into the health team working together as a team, but sharing in terms of client data? Is that a component of this?
Okay, thank you. First, I will just comment on the idea of social workers and that type of the people who are really important in the social determinants of health. I remember seeing, I was just looking at it, can't find it right now, but a graphic, I believe by Trevor Hancock, who is a public health physician from Western Canada, who does a lot of work on social determinants of health. And I think it was saying, something like, the real Ministry of Health, and it had like the Ministry of Social Services and the ministry, all these other ministries that were really, really important in promoting health. And then what we call the Ministry of Health is really the Ministry of Sickness, the way our system is run, because the true determinants of health are not looked after within the Ministry of Health. They're looked after in different ministries. So I thought that was interesting, because often I think we sort of beat ourselves up a little bit for concentrating on sick people, but our system sort of is set up that way, that the medical people deal with the people who have medical problems, and the social workers and the housing department and all those types of things deal more with the social determinants. Even issues that we talked about, transportation, I mean, that is rarely something that we as doctors, we can't start a public transportation system necessarily, or the healthcare system can't do that. So now who's on the team in technology? Yeah, again, I think this is going to vary from place to place. So in Ontario, we have family health teams, and in the family health teams, we have nurse practitioners, we have nurses, we have dietitians, and we have social workers who, interestingly, confine their practice to mental health counseling and don't actually work in a traditional social work role. So that's quite interesting. If someone needs traditional social work help, they go outside of our team to the social workers. So that's who's on our team right now. Within our team, information is shared. We have a common EMR, electronic health record, that assists with sharing with information. When we talk about technology, using technology. I always say, of all the technology I've kind of used, I still think that telephone is a really good method of communicating with other people. So sometimes getting too technological gets in the way, but everyone's got a telephone. So when you're in a problem and you need to talk to someone else about it, using the telephone works. We do have an Ontario telehealth network where you can do live appointments with specialists and that type of thing. But it does become quite complicated because the patient has to be there at a certain time. The physician has to be there at a certain time. You have to book because it's all secure link. It has to be on a certain system. So you can't just pick up your phone out of your pocket and call someone. So I think because of these technical limitations, although telehealth is catching on a little bit, it's slow. I know in some northern places they use it a little bit more because the advantage is much greater. It saves people a trip by airplane for a few hours, so they use it a little bit more. But again, in the north, you also have the limitation that the bandwidth is not necessarily that good, and so using telemedicine doesn't always work because of the limitations there. And again, the telephone does work in those situations. So I think it's great to have telehealth, and it works well in some situations, but the telephone works really well too still.
Okay, thanks, Margaret. And turning it over to Ray. It's also, I think, it's always a challenge of, working with multiple teams of communication among team members. And again, I kind of bring back the question of, including from telehealth, is like, how is client data shared among the different systems or so that, whether it's a nurse, a nurse practitioner, general practitioner, dietitian, do they have the essential information they need to properly care for a patient?
Yeah. And hugely important topic. I certainly, Pratyush and Margaret's comments are 100% on. To the question around who's the team, I think fundamentally the team is the team, is whoever you have there on the ground at the time. Now the challenge with that approach, so kind of I'm a very kind of simple kind of guy, and so that's the pragmatism that we have. I mean, I think there've been some comments or questions around, what's happening in Zimbabwe and kind of in low socioeconomic kind of situations, kind of how do you deal with the system and all of that kind of stuff. The reality is the team that you have is the team that you have, and so you do the best that you can with what you have in a very real way. But then there's that second question around who should be the team. And so I think this is the work that I really appreciate with it towards Unity for Health around the partnership pentagram. Pratyush was kind of alluding to that. So, and really, I think that needs to be driven at a community level by the partnership. So your policymakers, your health administrators, kind of whatever they may look like, providers, whoever they are at the time, the citizens absolutely kind of driving what this might look like, academia. We've been doing some work around adding kind of a group around a kind of non-profit and industry, because they also have a vested interest in health, but really kind of shaping kind of at a community level kind of who the team should be, and then actually looking at kind of trying to resource that. That's a big question. To your point around telehealth and data, both hugely important things, both really exciting fields, and both rapidly evolving. I always tell the story, shame my Canadian colleagues with my work in Zimbabwe, because health data travels better with my patients in Zimbabwe than it does in Canada, because my patients in Zimbabwe have an exercise book, torn in half, that they walk around with. When they see the doctor, they hand it to the doctor writes in it, then gives it back to the patient, and the patient walks off with that. In Canada, our patient data does not travel with our patient as well as that, because we have fragmented healthcare systems. So we have data silos. A colleague of mine, Granger, calls Canada the world of 100,000 silos. So you have hospital silos, you have clinic silos of data that don't follow with move around with the patient. I think the place that we need to be getting into is really modeling in an electronic world that same exercise book that my patients in Zimbabwe have. So patients, we need to democratize health data. It needs to be sitting with patients. Patient health records in probably Canada is going to be on a smartphone, and that's the piece that we're looking at working on. and it's just going to follow the patient wherever the patient goes. And I think we have an accountability to do that. And with technology, with virtual care, we're moving into, again, democratizing that. So not going from this traditional kind of video cart approach. It really, I think, democratizes the whole kind of interaction of the healthcare team again. And in particular, we're doing some work around how does a specialist kind of engage in primary care, because we all have a huge role. And we have a traditional model of a consultation model, clunky, where you write a referral, it goes off, then the patient, the specialist may see the referral, and then wants the patient to travel and all of that kind of stuff, to moving into a conversation. So there's no reason why we couldn't virtually pull whoever we need to pull into the room at the same time as the primary care provider is seeing the patient in the here and now, have a quick conversation around what's going on, get some advice and guidance, and then that person steps away and you have that relationship going on, whether it's with the midwife, with the social worker, with the mental health worker, with a general practitioner, with a nurse practitioner. It doesn't really matter. But actually move into a place where we can use virtual care. And I agree with Margaret, it's not just video, texting, telephone. There are a whole bunch of different ways where we can look at access virtual care that'll actually shift. It pulls the service around the patient, not pulls the patient into kind of the needs of the service and the service providers.
Thanks, Ray. So part of this next question really goes around current trends, best practices, and innovations. But there's a concept called disruptive innovation, which oftentimes means that where true innovation happens within an industry is really from groups that have to innovate out of need or necessity or demand. And therefore, that group of people actually informs the majority of people. So in this case, it would be like, what is remote and rural healthcare? How is that actually informing urban healthcare or healthcare as a whole? Because the general practitioners and the health team have actually had to innovate differently than when everything is in a geographic particular area. So keeping that in context, I'd love to hear from each of you in terms of what are those best practices and current trends and innovations, and how can I maybe incorporate them to my rural area around the globe from lessons you've made? And how should I be thinking about this to improve my own role in remote healthcare in my country? So, Pratyush?
So the current trends, as we were discussing around telehealth, the trends is moving towards delivering the healthcare services directly to the home. It could be because of our changing lifestyle and how we want our services to be delivered. We are less engaging with the workers. We hope that everything gets delivered on the fingertips, and that's why health is also have come to the apps, and more and more number of patients are accessing the health data or contacting doctors on the mobile phones. These are definitely some trends. And if we look at some artificial intelligence, where huge amount of money is being invested by these IBM and this Google, and these all things are going to come in the future. And as general physicians, we need to get ready to handle all these situations, that how we are going to manage those situations, because we cannot change the time. Time is here for the artificial intelligence, and we must learn that how we can safely utilize those resources, ethically utilize them, and make the best use of them without invading anyone's privacy or without letting anyone steal their data. So these are some of the trends. But apart from the innovation thing, is something which is happening in India, is that bringing the medical system, the clinic, in the community. Earlier the health centers used to be located in very urban areas, but now the new concept is called as mohalla clinics. It means that community clinics, so that a health system, the clinics are coming into the community. The next innovation which is needed is to bring the medical education to the community. It has been seen globally that those students who come from rural areas, or those who have done their medical education in the rural areas, are much more inclined to serve in the rural areas. So that could be the next innovation, to bring the medical education, just like how we bring the medical clinics to the rural areas. We need to bring back the medical education, the colleges and medical colleges to rural areas. That's why we can have much more rural health retention, the rural health workforce shortages, which we usually, we always claim that we have got huge shortages and we need to provide that. That could be one of the best innovation which we could do. And obviously the education system which we have, the much more specialist domination regarding the gynecology services we are talking about, that now the system is much more specialist dominated. We need to move forward towards the generalist dominated system, which caters to the need and provides the comprehensive services, even if, from birth to end of life care. The complete spectrum of care can be provided. So we need to move education system, we need to change, and we need to bring out innovative ideas that how we can deliver those education. And when we talk about education, we should never forget about the resilience, the workload, and obviously the patient dissatisfaction, which has led to many assaults on doctors. So we should also take care of all those things, that the physician should be resilient, and it should not be much more overloaded on doctors. That's all for me. Thank you.
I think that yes, different places around the world are at different stages along this line. I think in Canada, as far as bringing students out to rural areas, we're quite advanced in this department. We always have 5 or 6 students in our community, or students and residents in our community, and the teaching program has been going on for 30 or 40 years here, I think. So the idea of bringing students out to the community, I think, is very well established. I think we've also had the College of Family Physicians, which is our training body, has been quite supportive, and they recently released some what do they call it, guidelines, anyway, priority topics for evaluation of students in who are doing their rural medicine, or for residents. So our priority topics for rural residents include things like, I mean, a lot of them are emergency based, like dealing with septicemia or psychiatric emergencies, fracture and dislocations, that type of thing. But there are also ones that are clinical courage, Indigenous health, adapting to rural life. So within the last year or so, the college has has come up with these priority topics to just specify the types of issues that rural trainees have to make sure they get exposed to, which urban trainees may or may not. So I think from our rural exposure, we're doing relatively well in that department. Again, the issue is you get residents who come out and they really enjoy their rural rotation, but they have a spouse, or they have, family commitments in the bigger city. So I think many residents see it as a great learning experience, and they want to get out and see what medicine is like in small towns, but not all of them can actually do it on a long-term basis. Yeah, so I think in those departments we're doing well. The first 5 years approach, I think, is quite good to support people in their first 5 years of practice. In our team, working with our teams, that again is varying from place to place. I think I would, we have our team set up, but I think having perhaps more emphasis on social determinants of health might be appropriate. We have recently hired a health promoter onto our team who would be involved. I think the health promoters initially probably focus more on lifestyle issues like exercise and diet and that type of thing. But I think down the road, they will be drawn into the other social determinants of health. What actually can be done from a health team point of view as opposed to the other ministries, we'll have to see. But that is also emerging and changing. Yeah, those are the things that come to mind initially.
Yeah, no, really interesting conversation, and I'll pick up on a couple of pieces. So for sure, Pratyush, you raised this idea of AI and the complexity of the world that we face and kind of how we're going to manage it and deal with those things. And I've seen some of the comments on the chat box around, the centralizing effect. I think, Margaret, you spoke to this a little bit about kind of in the education world, how we're pushing back against that in a whole bunch of different ways in Canada. And there's a whole list of things that we're trying to do. But fundamentally, kind of my experience within the Canadian system, and I think in all systems, is there's this centralizing kind of effect, what I would call gravitational pull. Kind of really describe it as gravity because I don't think it's malicious. I don't think it's aimed at disadvantaging rural, but it does naturally disadvantage rural. I think it's just a natural force. So we really need the wisdom somewhere to actually push out against that, and our systems need to be built to push out against that continually, because if we don't actively push out against that in the education system, so teaching and teaching our providers in teams to work in teams, the whole idea of cultural humility, actually having that built into our systems, creating opportunities for people to learn and kind of have experience in rural environments are all important forces to push out against that. And so how do you set that up in a system is quite interesting, and it comes back to, I think, Pratyush's comments around the complexities of the other things that we have facing. And I do think, I was actually in a meeting with Bob yesterday, and just will reflect back one of his comments is that it takes wisdom to do that. And at a system level, I think that wisdom does potentially reside in an approach like the partnership approach, where, I talked earlier about the partnership at a community level, defining and driving what a community needs and who the team is at a community. And then at the top-down piece, at a system level, having that partnership sitting there to say, actually, this is what AI is looking like in our context, in our society. And this is actually the way that we need to move it. And it shouldn't just be the policymakers or the providers or industry defining that. It needs to be that kind of collective wisdom in doing that. And also then in building the system, how do you put those counter forces to the gravitational pull of centralization, which does naturally create these widening equity gaps. So if you don't do anything, the equity gaps are just going to get worse. And I talk about that in a community, and it's just in a country and globally. So we really need to put in those counter forces to prevent that, to move upstream, as we've heard a lot of comments about, to move into the education piece.
So thanks, Ray. So part of I think the next question really goes into government, public health, and their particular role within incorporating some of these best practices. And oftentimes, and that was actually brought up earlier in the chat and a question by one of the participants, was really, well, how do you do that? And so, if you consider your own regions, but also if you were to provide recommendations to people across the globe in terms of, what are the considerations or recommendations that you make to governmental policymakers or their role within public health to maybe incorporate some of these trends or best practices, and in the sense of how would you recommend people go about thinking about that, so that ultimately that it becomes a whole system and not just maybe individuals or education systems, but how does government play a role within this? So Pratyush?
Basically what we have seen in the low and middle income countries, the health policies are largely influenced by those what's done by WHO, World Health Organization. But our local context is different. Our local priorities always remain different, because local disease epidemiology, if you look at those things, may not work the same way in different parts of the same country. Like what's happened in the north part of India may not be happening in the southern part of India. So our health policies should be like individual centric. It should not be very broad, so that some people receive more and some people are just deficient of that. So for that, we need to have some healthcare models. We need to do a pilot. As a primary care physician, general physicians, we do understand that there is huge data gaps in low and middle income countries, especially in our regions. And whatever the policy which we make is based on the data which we take from the Western countries, which are largely more developed nations. So those data, relying on those data, the policies which we develop, they usually suffer from lots of inherent mistakes. And that's why some of our health outcomes are a little bit biased. So what we need to do much more. There should be much more focus on doing some research and developing some pilot studies, writing some policy papers, and based on that, the government may think to invest more, because government the main point is the money, because government is investing very less on the GDP which the government spend on healthcare is very less. So they want to have much more efficient healthcare system, that how they can utilize the less money to gain more and more benefits. So for that, they need to have much more investment, much more innovation, and more collaboration. And for where the collaboration is concerned, we need to collaborate with the private workers, the private doctor, private practitioners. We need to engage with nurses, paramedics, and here all comes all the health workers and everyone, those who are interested in improving the primary health care. The government needs to collaborate with them and integrate the health systems. Those works in the fragmented system, like the program-based management, integrate at primary care level, so that we can have a better health outcomes. And we also need to make sure that our health policies are economically sound, because if it's our health models are not economically sound, the government may never approve that. So before advocating any ideas, we must make sure that these are economically sound, these are legally possible in the countries, and obviously these are culturally competent. If it's not culturally competent, then even if government approves, there won't be any takers for that. So we must make sure, and we must make sure that it's it's based on the local demands. It's not that something which comes from the top to bottom, but it's come from the bottom to up. The bottom up approach should be there in the health policies, and obviously the advocacy by the physicians, by the health workers, by the population as at large, will help to improve all the situations. Thank you.
So I've just started to get involved in some advocacy work through the College of Family Physicians, and I think the first thing is we have to understand who has the power, who's doing the funding, and how the system works, because there are some decisions that are being made at quite a local level, some regional and some provincial. In Canada, most of our health is done at a provincial level. Yes, so who you have to work with depends a little bit on who has the power over that type of situation. So for some things, you are going to advocate directly with the politicians, and some it's going to be done at a more local level. I think one of the important things is to have all the members of the healthcare team sort of working together to sort of say, well, this is what we think is important when you move forward. And representatives from the different types of members in your healthcare team. So you have physicians and you have nurses and say mental health workers working together to come up with certain proposals. If you can find research to support what you're proposing, that's great, but some of these are new ideas and don't always have a lot of research behind them. And so when we're looking for change, sometimes we're trying things out that perhaps have not been well researched in the past. I remember going to a teleconference on change one time, and unfortunately I forget his name, but there was a physician from the Netherlands who was talking, and someone said, what was your most important lesson? He said, change rarely comes in leaps and bounds, but from continually pushing in the same direction, so things get nudged along. But basically the idea is that you just got to keep working on it little by little by little. It rarely comes all at once. So I think that's what we have to do. But yeah, get information and find out who the appropriate people are to talk to. So in our rural roadmap that we're working on, I mean, I think by getting many different groups to the table is important, but if we're talking about, so one issue as an example that we're talking about is transferring patients from small hospitals to big hospitals. And sometimes the big hospital is full or doesn't want to accept the patient. So how are you going to solve the problem? Well, you have to get the people from small hospitals and people to big hospitals down at the same table talking about these types of things. And those are not necessarily issues that you're going to solve by going to high levels of government, but might be solved at a more local level. So yeah, sorting through that and deciding at what level the advocacy is best done at.
Thanks, Margaret. Ray?
Yeah, thanks, Nick. Great comments. I think fundamentally, I think this is about curiosity. That's one really important piece. And the way a lot of things work in any system is through relationships and trust. And so, if we go to any of the partners and try and browbeat them or force them into our point of view or enter into a dialogue, those will end up in very different places. And so I would suggest actually approaching it from a point of curiosity, recognizing that we all have needs in a system, and Pratyush and Margaret kind of were alluding to some of those needs. Certainly the ministry has needs, so the government has a policy, and so kind of taking that curious approach. I think as a system, I'm really interested in actually measuring things like relationships and trust, because those things have an intrinsic value for a system to move forward. Also measuring things like holistic risk and holistic cost, because I think, as Pratyush was saying earlier, kind of those are metrics that are going to help drive the system in a way that makes sense rather than in a kind of a siloed approach. And then the last piece I'll add to this is just picking up on Margaret's comments around power. One of the things I love about the partnership approach is it starts providing a vehicle, and it's not politically correct to talk about power very much, but that's a real dynamic in any system. And so ministry has power, absolutely. Government has power in policy and in finances usually. But there are all kinds of power in a system to either make things move better or to stall things out. And I think those are coordinated through relationships and trust. But you have kind of the social mandate that'll come from citizens, the actual real need, identification of need. Providers provide a certain type of power by their clinical knowledge and clinical understanding. So if you look at all the the aspects of the partnership, it is almost another way of kind of talking about different types of power in a health system. And I think having open conversations and valuing all of those powers, not just saying that money drives everything, although it's all important, but actually just surfacing that conversation is going to be an important conversation at some stage, I think.
Yeah, great comments. And I think what you presented was really understanding the dynamics of the power and the policies. But you also, all three of you really talked about the process of how to do that. And even Bubble commented, it's really about engaging all the partners simultaneously. And so that's really the approach to actually for long-term change versus maybe short-term gains. So thank you for those comments. So we're almost out of time, but let's just do one last round of anything, the final comments that you may have that you want our participants to take away. So big takeaways for you and what the participants should leave with. So Pratyush?
Final comments is that let's all believe that the primary healthcare is the one we need to invest more for universal health coverage. Without primary healthcare and without looking at the rural and remote population, cannot be health for all and universal health coverage. Thank you.
Margaret?
I agree, and also would say that let's keep talking with other members of the team and also other members of the people who we were just commenting do or do not have the power, but to keep moving things along.
And Ray?
Yeah, I don't have a huge amount to add. I think it's exciting times, and I think kind of the relationships are important, and learning from each other and looking for synergy. I think there's always opportunities for win-win situations, and so rather than a kind of a handout kind of oppositional approach, I think looking for synergistic approaches.
Well, thank you to our panelists. Thank you for taking your time, especially for those who had to get up really early to do this. I hope it was beneficial and to all the participants, and thank you for joining us. We will send out, as we promised, the position paper to all the participants, and this is recorded and we'll get it reposted. So, but thank you for everyone for your time, and enjoy the rest of what's remaining of your day, or for those of you getting up, hopefully you have a fantastic day. Thanks, everyone.
Thanks, everyone.
Thank you.